Hello, I'm Dr Sonia Davison. I'm an endocrinologist and women's health researcher, and I'm delighted to present today recent studies on HRT and the International Menopause Society guidelines for HRT use. There are a number of abbreviations used throughout this presentation. Please refer to this list, which you can print out and refer to during the presentation. The International Menopause Society has recently looked at the role of HRT again, and really the focus is in those women who have active menopausal symptoms and are around the age of menopause. In these slides, their term for HRT, which is menopausal hormone therapy, MHT, is also interspersed with HRT. So what the IMS have done is looked at the role of HRT. They've produced 12 concise points with regard to how we think currently the role of HRT is in women around the time of menopause. So in terms of vasomotor symptoms, it is the most effective treatment for vasomotor symptoms associated with menopause at any age, but the benefits far outweigh the risks for those symptomatic women. So this is important that they're symptomatic, who are less than 60 years of age or within 10 years of menopause. So again, we're looking at around the time of menopause. It is also effective and appropriate for prevention of osteoporosis-related fractures in at-risk women who are less than 60 years of age or within 10 years of menopause. Looking at different forms of data, so randomised controlled studies and meta-analyses are amongst the best forms of data. Observational data, as you know, is a lesser form of data in terms of being evidence-based. So this is important. We're looking at estrogen only at the top of the slide and estrogen and progestogen HRT at the bottom of the slide. So when you tease it out like this, estrogen only HRT may decrease coronary heart disease and all-cause mortality in those younger women around the time of menopause. But when you look at the combination of estrogen and progestogen, there's a similar trend for mortality, but in most cases, the randomised control studies show no significant increase or decrease in coronary heart disease. When symptoms are limited to vaginal dryness or dyspareunia, local low-dose estrogen therapy is preferred. Many people are confused about progestogen, but when a hysterectomy has been performed, systemic estrogen only is appropriate and you do not need a progestogen. If the uterus is still there, even if there has been an endometrial ablation, additional progestogen does need to be added to estrogen HRT. This is very important, that the option of giving HRT around menopause is an individual decision, and really quality of life is very important. Health priorities are also important, and in terms of symptom relief, personal risk factors such as age, time after menopause, and the risk of VTE, stroke, ischemic heart disease and breast cancer all need to be considered in every individual. When we're looking at the risks of having a clot in the leg or lung or ischemic stroke, they do increase with oral HRT, but that absolute risk is rare in women who are less than 60 years. And interestingly, observational studies show that there is a lesser risk with transdermal therapy, and we don't have very much study data with regard to transdermal therapy. Breast cancer is a very complex issue, and the risk of breast cancer in those women who are older than 50 years associated with HRT is very complex to tease out. The increased risk of breast cancer is usually associated with the addition of a progestogen to the estrogen therapy and also related to the duration of use. And this is an important thing to tell patients. The risk of breast cancer attributable to HRT is small and the risk decreases after treatment is stopped. The dose and duration of HRT should be consistent with treatment goals and safety issues, and should be individualised without giving them a certain set point saying you'll be on this for 5 years or 2 years. We do prefer using the lowest dose for the shortest duration for symptoms. This is also a very important point about premature ovarian insufficiency. So women who have undergone menopause younger than the age of 40 years, we do recommend using some form of systemic HRT until at least the average age of natural menopause, so around the age of 50 years. And they don't have to be on HRT. This could be the oral contraceptive pill if it's appropriate for those women. We don't recommend the use of custom compounded bioidentical hormone therapy, mostly because we don't have any safety or efficacy data. There is a big concern that progestogen administration may not provide adequate endometrial protection. Hence, we don't recommend custom compounded bioidentical hormone therapy at this point in time. With regard to breast cancer survivors, the current safety data do not support the use of HRT. However, some women way after breast cancer may have significant issues with quality of life and symptoms and may need to be on low-dose HRT. This is definitely a specialist decision and only in the context of having breast surgeon and oncology support. So where did all of this come from? The Women's Health Initiative study really stirred the HRT world up. It was initially reported in 2002 and is the largest study of HRT use involving more than 16,000 American women. The age range in this study was 50 to 79 years of age, so quite a lot older than your normal menopausal woman who would present around the age of 45 to 55 years. The average age of the women in this study, in fact, was 63 years. This study followed on from observational studies that showed that women who had HRT had lesser amount of heart disease. So this study was designed to see if HRT would reduce the risk of cardiovascular disease and cardiovascular events. The HRT used in this study was only one form. They used conjugated equine estrogen and metroxyprogesterone acetate in those women who had a uterus versus placebo. Women who had had a hysterectomy only had conjugated equine estrogens. The women were on this study for 5 to 7 years, and the first results were reported in 2002. This is our biggest and longest HRT trial to date, and our current knowledge of the risks and benefits of HRT is mostly based on this trial. So some further studies have come out after WHI was released. What we really want to know is what are the risks of HRT in younger symptomatic women. So the KEEP study is called the Kronos Early Estrogen Prevention Study. Again, this is a US-based study, and the aim was to determine if HRT in early postmenopausal women prevents arterial disease. It was a 4-year randomized controlled study, and the primary outcome measure was the rate of change of carotid intimal medial thickness. Because these women are young, we can't really detect heart disease and heart events because there's just not going to be enough in this age group. So they were using surrogate measures such as the carotid intimal medial thickness. This study also had secondary outcome measures such as change in coronary calcium score, lipids, clotting factors, and inflammatory markers, which in large populations have been shown to be predictive of heart disease and events. They also looked at cognitive and affective scores and quality of life in the women. The KEEPS study groups, on the left there, you'll see a lesser dose of conjugated equine estrogen was used compared to the WHI or Women's Health Initiative study, which used 0.625 milligrams per day. This study used 0.45 milligrams per day and compared this to a group which had transdermal estradiol of 50 micrograms per day, and a further group had placebo. So this is very interesting that now we're having the first studies come out looking at heart disease risk factors and also looking at transdermal estradiol. Most of these studies are performed in the US, and traditionally they don't use a lot of transdermal estradiol, and effectively the most used HRT product to date for estrogen was conjugated equine estrogens. The women also had a more natural form of progesterone, which was micronized progesterone, 200 milligrams per day for 12 days per month, or a placebo treatment if they were on placebo. This study was conducted over 9 US sites and had 727 women participating. So remember back to the WHI, or Women's Health Initiative study, that had more than 16,000 US women. So a much smaller number was on this study. The women were within 3 years of menopause, so much different to the WHI study where they were up to 79 years of age. They were claimed to not be heavy smokers, had severe obesity, coronary artery disease or hyperlipidemia. A lesser number of women participated in the cognitive and affective ancillary study. When we look at the results of these studies, they have been reported at the North American Menopause Society meeting in the USA, but there has been no publication yet from this study. The age was from between 42 and 58 years of age, but was a mean of around 53 years. Almost 2/3 completed the whole study, so there were some dropouts. And the results of these were for both the conjugated equine estrogen and the estradiol patch. They found there were lesser vasomotor symptoms, higher bone mineral density, and an improvement in sexual function, seen by increased vaginal lubrication and decreased dyspareunia. There was no net effect on blood pressure or carotid intimal medial thickness, and no net effect on cognition or memory in either types of estrogen. This is where the findings separated out somewhat, and these were all significant findings. For conjugated equine estrogen, there was a difference with regard to lipids. This promoted a more favourable HDL profile and a lowering of LDL cholesterol, but also increased triglyceride levels. C-reactive protein was found to be elevated, but there was no net effect on interleukin-6, and interestingly, depression and anxiety scores were less in the group on conjugated equine estrogen. With regard to transdermal estradiol, there was no net effect on cholesterol or inflammatory markers, and a favourable effect on blood sugar and insulin sensitivity, and interestingly, an increase in sexual desire and arousal. With regard to coronary artery calcification, there are two groups there, and you can see by the columns that those who had a baseline score of 0 with coronary artery calcification and more than 0. You can see that both the estrogen groups, conjugated equine estrogen and estradiol, had a lesser amount of significant deposits of coronary artery calcification at 4 years. However, there was no statistically significant finding between groups. With regard to adverse events, there were no significant differences between the conjugated equine estrogen, the estradiol, and the placebo groups for breast or endometrial cancer, myocardial infarction, TIA, stroke, or venous thromboembolic events, but the number of absolute events was very low. We're coming up to another study now, which was DOPS, the Danish Osteoporosis Prevention Study, which has been published in the British Medical Journal. This study aimed to determine if HRT in early postmenopausal women prevents osteoporotic fractures. It was a 10-year study with an additional 6-year follow-up. Interestingly, this study was terminated before its estimated time of completion, and this was because of WHI. The results for WHI were presented and reported, and because of the increased risk in breast cancer associated with HRT at that point in time, which was 2002, the study investigators for the DOP study decided to terminate the study at a shorter interval. So the primary outcome measure in this study was osteoporotic fracture rate. They also did a thing which we probably shouldn't do statistically speaking, and that is they combined a number of factors for a primary endpoint. And they combined AMI, heart failure and death, and called that a primary endpoint in combination. With regard to the study treatment on this DOP study, for those who had a uterus in situ, they had a combination treatment known as trisequins, and this is oral estradiol 2 milligrams per day for 22 days of the month, 1 milligram a day for 6 days of the month, and norethistone acetate as the progestogen at 1 milligrams per day for 10 days of the month. In those women who'd had a hysterectomy, they only had oral estradiol 2 milligrams per day. And this is where the criticism of this study lies, is that there was no placebo group and there was just a no treatment group rather than a placebo group. This is the process of selection of women for this study. 2016 women were healthy, recently postmenopausal, or also symptomatic perimenopausal women from 45 to 58 years of age. On the right, you will see over 1,000 women participated in an observational study, and 1,006 women went onto the treatment arm of the study. Of these women, 19% had had a hysterectomy. Of those who took HRT, there were 502 women, so a combination of estrogen and progestogen were 407, and in those who'd had a hysterectomy, there were 95 women who had estrogen only. They had 504 controls, which included 97 women who'd had a hysterectomy. When we're looking at the baseline characteristics, the women were essentially just around the time of menopause, and the control group was slightly older than the HRT group, the controls being 50 years of age mean, and the HRT group being 49.5 years. Otherwise, there were no differences between the group. They'd had a similar time since menopause. They had a just overweight range BMI at 25 or so. A large number of these women, interestingly enough, were smokers, with 44.6% in the control group and 42.3% in the HRT group. The other interesting thing in this study was that their cholesterol levels were elevated at 6.3 millimole per litre average. This is the 10-year result, and remember the combination endpoint at the top left-hand part of the slide was the combination of death, heart failure or AMI. So there was a significant difference only with regard to the combination endpoint and also for heart failure. But these all really favoured HRT. So you will see in the HRT column, the numbers of events in each of these columns were actually less for the HRT group as compared to the control group. And remember, the control group had no treatment. It wasn't placebo treatment. So a combination endpoint was significantly lower in those women on HRT, and heart failure was significantly lower in the women on HRT, but there was no difference with regard to the findings teased out, such as death, AMI, cancer, breast cancer, DVT or stroke. There was no difference in those single items between groups. This study again had a follow-up up to 16 years, and again you will see that combination endpoint of death, heart failure and AMI was statistically significantly different and favoured the HRT group, with a lesser amount of primary endpoint in the HRT group as compared to the controls. However, no other factor, including heart failure, crossed the line for statistical significance with regard to difference between groups. The other interesting thing from the DOP study is in the hysterectomized women, there was a reduction in the risk of death and the risk of breast cancer found in the estrogen-only treated women, with a hazard ratio of 0.42. So the overall message from DOPS, this supports the concept of a window of opportunity with regard to HRT use. So when we're using HRT, use it around the time of perimenopause or menopause in symptomatic women, and they will get the benefit, rather than wait many years after the menopause to introduce HRT, such as was the case in the WHI study. In peri and early postmenopausal women, 10 years of oral estradiol and norethistone acetate in those women with a uterus in situ appears to be quite safe, despite the fact that these women had an overweight BMI and there was a high percentage of smokers, and there were also lipid abnormalities.
In terms of the ELITE study, this was the most recent study looking at the intervention of HRT and cardiovascular disease markers. The ELITE study was the early versus late intervention trial with estradiol and was aimed to determine if HRT in early postmenopausal women prevents arterial disease. It was a 4-year randomised control study, and the primary outcome measure was the rate of change of carotid artery intimal medial thickness, being a surrogate marker of cardiovascular disease. There were also secondary outcome measures in this study, including neurocognitive function, cardiac computed tomography, and measurement of coronary artery calcium and coronary artery lesions, again as a marker of coronary artery and cardiovascular disease. In the ELITE study, there was a group of early postmenopausal women who were less than 6 years postmenopausal, and a group of later postmenopausal women who had been at least 10 years after their final menstrual period. The treatment involved oral 17-beta estradiol of 1 mg dose versus placebo, and they had a vaginal micronized progesterone gel of 4% of 45 mg or a placebo gel given sequentially for 10 days per month. And there has been a lot of interest recently in having a more natural progesterone, and micronized progesterone is very close to the body's endogenous progesterone. This study was organised by the University of Southern California, performed in the US. 643 women were enrolled, and they had up to 5 years treatment. In terms of the early postmenopausal group, there was a lesser number. They were aged 55.4 years median versus the older group who were 63.6 years. You'll see that the time since menopause was 3.5 years in the early menopausal group and 14.3 years in the later menopausal group. The later menopausal group was slightly more overweight, and the most significant difference apart from age and time from menopause is the cardiovascular type medications. You will see in this table that the late postmenopausal women had a higher percentage of antihypertensive use, lipid-lowering treatment, and also, most significantly, past HRT use compared to the early postmenopausal group. This is where the significant difference was, and this has been recently published. At the top of the slide, the straight blue line followed by a hashed orange line shows you what happened with the late postmenopausal group. They had more carotid artery intimal thickness, or a higher measurement. However, there was no difference when estradiol was introduced compared to placebo, and that's comforting in itself, that women prescribed estradiol had no change in their carotid artery intermedial thickness sometime after menopause. What you can really see here is in the early postmenopausal group. This was where the significant difference was. Those women who were prescribed estradiol actually had less carotid artery intimal thickness, and you can see that there's hardly any progression versus the women who had placebo, who had a slight increase in carotid artery intimal thickness. So the difference was really in the early postmenopausal group, and supports the window of opportunity such that if estradiol is introduced early after menopause, then there's probably going to be a cardiovascular benefit. In terms of adverse events on the ELITE study, there were no significant differences between groups for breast cancer, AMI or VTE, but there were a very low absolute number of events in this study.
These final slides are very useful with regard to talking to your patients about the risks and benefits of HRT. The American or US Endocrine Society went through all of the key studies with regard to HRT use, And they tried to take out the older women from these studies. So they just tried to focus on the normal symptomatic women who would be presenting to a general practice or to a specialist for treatment. So these women were 50 to 59 years of age, all less than 10 years after menopause. And you can see on the right of the slide, this was favouring a benefit, and on the left of the slide, to the left of the black line, that's where there is a risk. So you will see for hot flushes and vaginal atrophy, the black bar is estrogen only, and the white bar is estrogen plus progestogen, but their symptoms were markedly improved with regard to both of those symptoms on HRT. This is compared to the risks which appear in the second half of the slide here. So for fractures, diabetes, breast cancer, etc., down to cholecystitis, you will see that there are risks. However, really they're a blip on the radar compared to the symptom improvement you can see at the top. The next slide is a blow-up of the second half of this slide. So again, this slide is a blow-up of the previous slide, the second half of it. So it's looking really at the risks and benefits here. And again, estrogen only is in the black bar, and estrogen and progestogen is in the white bar. So you will see for things like fractures, diabetes, overall mortality, and coronary heart disease, both estrogen and only and estrogen and progestogen groups in these younger women or those close to menopause had a net benefit from HRT. Where the differences lie, estrogen only, there was a net benefit for breast cancer, and the combination estrogen and progestogen, there was a net risk for breast cancer, but this is related to the WHI study, and that is after 4 to 5 years of use. For colorectal cancer, there was a benefit that was mostly seen in the estrogen and progestogen group, and for endometrial cancer, again, there was a similar benefit for the estrogen and progestogen group. So where we're looking mostly at the risks, apart from the breast cancer in the combined group, is for venothrombotic episodes, which were similar in terms of they were a risk for the estrogen-only group and for the estrogen and progestogen group, but more marked in the estrogen and progestogen group. Again, stroke was a risk for both groups, and the main risk you'll see for HRT, which is somewhat fascinating, is there is a risk for cholecystitis. Thank you very much for listening to the presentation, and I hope you've learned some more about appropriate HRT use in younger women around the time of menopause. Many thanks for your attention.